देखिए लाइव आया क्या?
नहीं सर अभी
Okay, it is live on YouTube.
Is it?
Yes, it's live on YouTube.
You all need. No. Yes, we are. Okay, here we go. नहीं है ना 23, 26, 30, 800 plus.
Welcome everyone. My name is Dr. Gurudat Naik. I am the principal of Mansoor Dental College, Bhopal. Thank you all for joining us for today's webinar. Mansoor Dental College was established in 2007 by Sai Gramottam Samiti under the vision and guidance of our legendary Mr. K.K. Tiwari sir, Chancellor, Mansoor Global University and CMD, Mansoor Group of Institution. Today, under the dynamic leadership of Mr. Gaurav Tiwari sir, CED, Mansoor Group of Institution, we have emerged as the premier dental college in Central India. To spread the knowledge of dentistry among dental students and practitioners alike, our institution has been regularly organizing various webinars. In this chain, today we are hosting a webinar on fixed prosthodontics, simplified in today's time, impression, crown, and bridge material choice provisionals by Dr. Akhil Reshamwala. We are honored to have Dr. Akhil Reshamwala, an eminent speaker, who accepted our invitation on a short notice to conduct this webinar for us. Without further ado, I will turn the time over to my co-host, Dr. Sagar Khanna, who is a professor in the Department of Conservative Dentistry and Endodontics, Mansoor Dental College, to give a brief introduction of our speaker.
Thank you, Dr. Gurudat Naik, sir, and a very good evening to my colleagues, friends, students, and teachers who've logged into this very anticipated webinar today evening by Dr. Akhil Reshamwala. I'm sure you all have heard of this phrase, friend, philosopher, and guide. That's exactly what Dr. Akhil Reshamwala has been to me. I was privileged enough right from the earlier part of my career to be associated with him as an endodontist. My earliest memory of Dr. Akhil Reshamwala should be about the year 2008-9, when myself as a postgraduate was attending an interdisciplinary conference in dentistry, and Dr. Akhil was one of the speakers, and I could see students and delegates literally throng in to attend his lecture. That's when I realized the popularity that Dr. Akhil Reshamwala holds. Over the years, I have known Dr. Akhil Reshamwala as an ace clinician, a master prosthodontist, but more than anything else, a fantastic human being. He's not only mentored me, but he's also mentored a lot of young budding dentists who hold him as an epitome of prosthodontics. It's a privilege for me to introduce Dr. Akhil Reshamwala to all of you, who actually, to be very honest, doesn't need an introduction with the fame and accolades he's already accumulated, but I would be giving you a very brief introduction of this gentleman. Dr. Akhil Reshamwala is a practicing prosthodontist and implantologist from Mumbai. He's completed his BDS from Mumbai University in 1997 and master's in the field of prosthodontics from the University of Queensland, Brisbane, Australia in 2001. He was a visiting faculty at the same university. He is a fellow of the International Congress of Oral Implantologists, USA, and a fellow of the ITI. Being a key opinion leader, he's lectured as a keynote speaker and performed hands-on and live clinical procedures extensively, both nationally and internationally, on topics pertaining to prosthodontics and implantology. His topics have covered subjects of complete dentures, post and course, fixed prosthodontics, full mouth rehabilitation, implant prosthodontics, single tooth implants, full arch implant rehabilitation, and occlusion. He conducts courses and hands-on on the topics all over the country. He has been awarded as a certified trainer and facilitator by Middle Earth Consultants. He is the recipient of the Outstanding Student Award at the International House, Brisbane in the year 2000. Dr. Akhil Reshamwala, it's a privilege to have you at Mansarovar Global University. Thank you for taking your time off from your busy schedule. The stage is all yours. We welcome you and thank you very much.
Thank you very much. Firstly, I would like to thank Dr. Nayak and Mansarovar Global University for inviting me on this podium. Secondly, my thanks goes to Sagar. Now, I'm not going to call him Dr. Sagar because I've never done that in my entire life. I know him more as a friend and a colleague than, and he told you all about the things that I have done, but I wish I get the chance to tell you all the things that he has done in his life. And he is as popular or probably more than what I may even be worth. So with that, I would like to start the presentation today. And the presentation is basically Sagar and Dr. Nayak, with your permission, can I please share my screen?
Yes, sir.
Yep. So there we are. I'm going to try and take this screen as further away as possible. No, I don't want it. Yeah, okay, I think, is that good?
Yes,
so I'm going to start
my
presentation today about fixed prosthodontics and how we take this, because this is a very, I would say, when Sagar asked me to do this topic, it was I had to literally pull it out from my archives. Reason being because now I've been talking a lot on other topics, and they said, let's start with something which is very prevalent to everybody rather than trying to only talk to a certain group of people. So with this, I would like to, there we are. I would like to say that Arios is, my clinic's name as well as my academy's name, where Arios stands for the word or meaning of Arit, and Eos is the rising sun. So together it comes as excellence on the rise, and that's how we coined this word. And this picture that you see down here happens to be of the city Brisbane, where I did my master's. And if you see this particular building here, that used to be my dental school. So this is where I did my master's from, and whatever I have today, I'll be sharing from my experiences there. Hopefully, after watching my webinar, you won't do things like this, but you'll follow whatever I have to say, and you will apply it to your patients in the most practical way possible. So what I'm going to start with today is basically an impression. Now, what is an impression? It is nothing but a negative of the positive. It is nothing but a media to replicate the original. So if you look at this, whereas if this is the original, this is the replicate or the duplicate. So this is how life is. So if you get your impression right to your lab technician, the lab technician is going to love you, and that's how you will get the best crowns that fit in your clinic. So margins, fit of crowns, these are things which are recorded in that impression. So please don't be in a rush to finish that impression. Don't be in a, what we call, I call it a state of anxiety. There are times when I used to do full mouth rehab impressions, and I always used to be tense. I think, you need to slow down, take a deep breath, and then approach this step this procedure of fixed prosthodontics, whether it's fixed prosthodontics or implant dentistry, whichever way. Today, I'm not going to talk on implant dentistry, but more to do with natural teeth. So if your margins and the fit of the crown is good, tell me, how much time do you save at the trial or cementation? Sorry. Sorry. So amount of time that you save at cementation. Now, how much time would you give your staff to put for a cementation appointment? Would it be 10 minutes? Would it be 15 minutes? Would it be half an hour? You know, there are days when you are doing a single crown and you're going, you know, you check the bite and you go, and you're continuously adjusting and adjusting and adjusting the crown. And many a times you even adjust the opposing arch because you finally that crown doesn't want to fit in, and you have to somehow, you promised your patient that the crown is going to be delivered today, and you are doing your best to get it across. Now you want to avoid all of this. You want to also get long-term prognosis of the prosthesis. Tissue health around the prosthesis. Many a times we see crowns that come to my practice done by somebody else, you know, or you see that the entire tissue is so inflamed. So, you know, an impression is basically the link between you, your technician, and the patient. So if you've done a crown prep on a patient, you as the specialist, I call you as a specialist because you're a dentist, and a dentist by himself is already a specialist. You don't have to be an endodontist, a prosthodontist, a periodontist to be called a specialist. This is what my belief is. And then you send it to your technician. So the link between all the three is your impression. Now, impression materials. What are the different types of impression materials that you would use? Anybody over here, I don't know how many of you have ever got a chance to play around with agar-agar. I did once in my life where we had to put those pipes with trays in the mouth and hot water and cold water, and it was a mess. And after that day, I never went back to that material. Alginate, probably our go-to material for most things. And I also don't want to say this aloud, but there are times where I know alginate is being used as a final impression material. It's not a material meant for a final impression. It is a good material for study models, opposing arches, and all of that. Polysulfides. If you happen to be of the same age as I am, you would have probably seen polysulfides actually just leaving the dental industry. They smell, like they literally smell. So imagine putting something which is a very bad odor or a flavor in the patient's mouth. Your patients, you know, even your normal patients will start gagging and probably throw up. So that's a material that we don't end up using. Polyvinyl siloxane is probably the most commonly used material today, but not the condensation. I would definitely recommend the addition silicones. And polyethers, not many people stick with polyethers. There are very few people who use polyethers. I am one of those people who really loves his material, which is polyether. So we'll talk about all these materials and why we would use what. Alginate, we've all studied and know about imbibition, syneresis, you know, all these things. So that is the reason why we do not recommend alginate as your final impression material. Secondly, the surface tension. They always, when you pour an alginate model, you have blobs that you see on the cast. If you're using it for an opposing arch impression, please make sure that you take a number 15 blade and you just remove all these blobs. These interfere with the occlusion. So when your technician is getting the upper model as well as the lower model together, and one of them is an alginate poured model, whichever material stone or die stone that they have used, you will find that they don't fit too well. And we don't want that, okay? So let's talk about PVS and polyether here. Now, what is PVS? It is a fantastic material, most commonly used material today for final impressioning. It develops elasticity very rapidly, but at high temperatures. So you need to have it at a cool area. Now imagine, let me give you a hypothetical scenario. Today, none of our clinics probably are without air conditioning. But if you are working in a non-air conditioned clinic, you will find that this material sets very fast. Now, what do you do? What do you do for cities that reach temperatures sometime in the summer? I know a city like Nagpur had reached almost 48 to 50 degrees centigrade. You cannot, even your air cons with the air cons on does not cool down the room temperature. So what do? There's a trick here. I put my polyvinyl siloxane in the fridge. Nothing will happen to it. It gives you longer working time, does not alter the setting time. So the setting time remains the same, but you get longer working time, and later on it will go into that set. So whereas a polyether, whichever the temperature, it remains plastic for longer. My request is you never put polyether in your fridge, because the base and the catalyst don't mix after that. The final stiffness is less than polyether of polyvinyl siloxane, whereas final stiffness is more in a polyether. That is why also it is the gold standard material for implant dentistry. Let's talk about consistencies. What are the different types of consistencies? Heavy body, putty. You have light body. So heavy body forms the base. Your light body is meant for more accurate impressions. Then you have an ultralight body. Now, ultralight body came into being where, if you have done an impression and you missed out a few things and you wanted to capture it, you could use ultralight body and put the same impression back in the patient's mouth and it would capture it. How many times have I used that? Probably once or twice just for trial, but I don't think you will need that consistency if you follow the certain rules and regulations that I've laid out for impressioning today. Medium body and monophase. I love this material for all my complete denture cases, my removable partial, cast partial cases, where you need a little bit of accuracy, but you also need that stiffness to record all the borders and the vestibular molding and stuff like that. Accuracy. Now, according to the ADA specification, you need to record 25 microns. Okay. Now, the lower the viscosity, finer the detail. That is why you need the light body along with the heavy body, or the putty as we know it, to record your final impressions. Now, because a putty material can only record up to 75 microns, you need to reline it with a light body, which goes up to 25 microns. What is the acceptable margin around a crown by the ADA specification? It is up to around 30 to 40 micron. Now, what is 30 to 40 micron? Can I see it? No, but I can feel it. How do I feel it? A brand new probe, a really sharp U-Freddy probe, if I take it along the margin and I run it from the tooth, that means the root area, towards the occlusal surface or the incisal surface, if I hear a tick sound, that means I have picked that open margin. Ideally, you should not hear it. That is how you check the fit of a crown. And that's why for critical areas, putty is not recommended. I will show you, I have certain demos today through this presentation where I'll be showing you where I have used only putty, but I need to reline those also with light body. Pre-impressioning. Can you just plan your case to walk in and say, okay, let's do an impression today? No. There are very few cases in my practice that I get away with doing an impression immediately. So first you need to, of course, have the tooth prepared, or for whatever you are doing it, whatever prosthesis you're going to place on top of it. Then what we don't look at is the soft tissue. Today dentistry is all about the white and the pink. We tend to forget the pink. We only stick to the whites. All right? We are like those horses with blinds. All we look at is the white. No, we need to look at the pink too. Now, example, look at this case here. Very typical lower molar, huge class 2, which ended up with a root canal. We've done the root canal treatment. Now, whilst you're doing all this, what happened here? That we never paid attention to that tartar around the soft tissue. Now, when this patient walks in like this, you're going to do a core buildup, right? Once you do the core buildup, you're going to prep the tooth, and now you want to take an impression. So if on day 1, when this patient walked in for the root canal, I go ahead and I, take care of this tartar around here, what is going to happen in that 1 week of waiting period between the root canal and the core buildup and all of that? Patient's tissue is going to heal. It's going to take away the inflammation. Now, if I go ahead and prep this, you're going to have a nice inflamed tissue there, which is not a good area to pick up an impression. Please spend time fabricating provisional restorations. There is probably, I would say, 1 or 1.5% of my patients that walk out of my practice without a provisional restoration. Reason being, you don't have a provisional, teeth supraerupt, teeth migrate, teeth tilt, all this happens. And for people who may have faced this, pre-lockdown, you've done a prep, you've sent the patient away, government decided to have a lockdown, we shut down, we go back to our clinics 3 months later, you try to fit that crown which had come back because the patient couldn't make it pre-lockdown. And suddenly you realize that the crown is not seating. It is not fitting in. Why? Because you didn't have a provisional there. You know, every time that you want to reduce your chair time for a crown delivery, a bridge delivery, please make sure you have a perfectly fitting provisional restoration. I actually spend more time or equal time doing my prep and my provisional, you know. So it's perfect. The tissue has to be good. The margins have to be perfectly sealed. And the material that I like to use is Protem. And then I will show you with my pictures later how I do that. So clean the tooth with pumice, water, glycerin paste, any of these, prophy paste, before you take your impression. Don't let the impression have, you know, stuff all over it. I mean, the tooth, a lot of stuff all over it. Sensitivity. You're doing a vital tooth prep. You've done the prep. What would you do next? I do what most people would probably not know why I'm doing this is, but immediate dentine sealing, IDS as we call it. All right. Professor Edward McLaren, Magna and Pascal, they have recommended this so that what happens is you basically seal the dentinal tubules. If the dentinal tubules are open, there is sensitivity. So every time you need to just, you know, say for example, you need to do a trial, a BIS trial for your crown. You remove the provisional and you're placing that in, it's sensitive to your patient. Then you have to re-inject the patient. To avoid all of that, all right, you just apply bond. And which bond could you apply? Not the regular bond, but the dentine bond. That the one which I like to use is single bond universal from 3M. So I apply that, and I cure it. Now that gets picked up in my impression. So you do this prior to impressioning, not post impressioning. Otherwise, your space for your cement layer is going to get affected. Yeah. Do you polish or do you not polish your tooth preparations? So Darwin, he was my professor. He taught me, and he said there was no difference, but I kind of didn't agree with him. Gundler suggested that increasing the roughness might increase the retention. But in 1997, it was proved that your retention increases by 55% if you have run a tungsten carbide polishing work over the dentine surface. All right. So why this happens is, if you look at this picture, it's a very rough sketch which I have done. So you have a tooth surface. The tooth surface is created, that roughness is created by your diamond point that you use on it, right? Whereas the crown surface, the roughness is created by the sandblasting done by your lab. Now, sandblasting is done by 40 micron aluminum oxide particles. Whereas
Akhil sir,
yes.
my apologies to interrupt you. There is a slight overlap that is coming with your presentation from your end. We can see, you know, kind of two slides coming in together at times. Can you just check that, please, from your end?
Oh, meaning when you say two slides, meaning?
When, for example, if a slide is there, you can see your first slide cut tooth also visible on a part of it. And also the diagram that you have now, it's overlapping on the matter. Yeah, now.
Yeah, that I have done on purpose because I don't want it to, one sec, let me try this. Check now, Sagar.
Can you go ahead with your matter?
See, now this is overlapping.
Okay.
Is this okay now?
Okay, please go ahead, sir. Yeah.
And then it disappears when I don't want it. So let's go back
Okay.
because I needed that. All right. So, okay, I need to go back a slide. Yeah. Is it okay now, Sagar? Please tell me if everything is good. All right, so let's come to this point here. So what is the weakest property of a cement? It's your tensile strength. It's not your compressive strength. Now, what is tensile strength? When the crown tries to come off the tooth is when the tensile strength comes into play. So if this is the longest bit, where is it going to crack? It's going to crack somewhere here. And then that crack goes up the tooth and below. And that's when you have the the crown in the patient's hand, and the patient comes back to you saying, Dr. Saab, nikal gaya, right? So you want to avoid that, and that is why you need to slightly polish these preps. So you don't need to polish them to this, the shine that you see on the car. It's like really smooth. There's no even air going to hold on to it. You basically need to polish up to a medium. So the coarse and the medium, these are, what are these? These are all composite polishing, cups. So don't go down to the fine, not required. A medium and a coarse will be more than enough. What are these for? These I used to use for my amalgam polishing when amalgam was used as a core build-up material. Then we use the cast post and cores. Cast post and cores also need to be polished. Now, tray selection. How do you measure what tray you need to use for your patient? I've seen in practices, they have trays kept in a drawer. You open the drawer and then you see that, your assistant is like going through the entire drawer and he's trying to pull out something and give it to you. And you say, put it in the patient's mouth, you remove it. Put it in the patient's mouth. No, it's not going. It's hurting here, there. And then you tell your patient, no, it's going to hurt somewhere. It's okay. Just push it in. I'll tell you a very simple trick that I use. I use the dividers. Yeah, any divider you can get from your stationery shop. You remove the sharp bits, take a carborundum disc and round them off. Use anything, use a stone if you like, round that sharp bit off, make it really blunt. And all you have to do is put that divider in the patient's mouth like this. You give it to your assistant and they go into your cupboard. They check on this and they get you your tray. So the trays have to be, sterilized and pouched like this. Don't leave them open, especially in these times where we need to be extremely careful. So this is a good trick. You'll find most times when we do this trick, and the tray literally fits in. Very rarely, sometimes you might have in the posterior region, you take a, orthodontic plier and slightly, mold that tray to fit in perfectly. But don't jump this. Trays are made as stock trays. If you're using a custom tray, which I will show you a little later, then of course you can even use those. They are the best. They should fit comfortably without touching any tooth or impinging on any tissue surface. And the special tray, you must always check that they are 2 to 3 mm above the vestibule. We are not doing border molding for crown and bridge dentistry. We need teeth. Those casts, the models that they make, the technicians, when they section it, you've seen they've removed everything else. They only have the teeth with the dies trimmed together. You don't need the borders. So please don't push. And you need a uniform bulk. That is why a tray should have equidistance from both sides, the lingual as well as the buccal. Yeah. Now, what happens in uniform bulk? You have first the monomeric units, then they cross-link, which causes shrinkage of the impression, which is then compensated by the expansion of the gypsum. That means your die stone, right? How do you position your tray? Correct positioning of trays. See, I've seen, and I've also, I used to do this. I used to have this concept that the harder I push the tray into the patient's mouth, the better my impression. It's actually just the opposite. When you push your tray really hard into the patient's mouth, you basically end up touching the vestibule or the palate in this scenario, right? Now, what happens? All the excess of this particular material has to come out. It has to come out. Unfortunately, because the tray is touching the tissue, it turns in. When it turns in, all this area that you have done your retraction will collapse. So you'll say, Akhil recommended me to do cord retraction. I am doing that, but when I'm taking these impressions, none of these retracted areas are coming through. So what my suggestion is, when you place the tray, make sure it covers the tooth and let the excess come out from both sides. Let it roll over onto the tray. There is nothing wrong in that. Yeah. So don't push too hard. Do we always need an adhesive, or can we jump that? Why do we need to order adhesive for any impressioning material? For alginate, you don't need adhesives. But for polyvinyl siloxanes as well as polyethers, definitely you need adhesive. Now, you know why you need adhesive? Now, look at these pictures. When you look at these pictures, you say, oh, there is full mechanical retention. This material is never going to budge. But how long does the tray stay in your mouth? What is the working time? Maximum 3 to 4 minutes, max, for any material, right? You remove it and you put it on your table. You realize that this material is still undergoing a process of polymerization and shrinkage, and it shrinks as it is lying on that table. How long does it take for you to reach that tray to your lab technician? Probably a day, probably that evening. I do not know, depending on your geographical position from your lab. Mine would take a good overnight time for it to reach my lab. Yeah. Then only the lab technician gets it and he starts pouring that on. So during that time, if it's shrinking, what is happening? The material is leaving away from the tray and it is warping. You don't want that to happen. That is why you need an adhesive to hold it in place. Otherwise, the dies of your crown prep would have shrunk. And that means your crowns become too tight and then they don't fit. And then what do you end up doing? You pick that burr, you hold the crown, and you make it really wide. And then what happens? Whoa, they become very loose. And then you rely on a cement to hold your crown in. You can never rely on a cement. Cement is a luting agent. It is not a bonding agent. There's a difference between luting and bonding. Luting is where you only need that material to fill up the space in between that crown and the tooth, and that's what it will do. A bonding agent is where it joins or bonds two surfaces together. And you don't want that in this case, except for one particular crown, which is lithium disilicate, which is Emax. We shall discuss about that also later. Adhesives. So adhesives, I used to do this. I used to prep my tooth, right? Do everything, then pick my tray. I do my tray selection. Once I've done my tray selection, then I'm like, okay, give me my adhesive. When I'm applying my adhesive, I pick up my three-way syringe, trying to dry it. You know what happens during that time? That adhesive is not properly dried. And because of which there are certain areas which will leave the tray. So ideally, you do your tray selection prior to your crown preparation. You do the tray selection, you apply the adhesive, you keep it on the table, let it dry. By the time you have enough time for you to finish the crown preparation, you finish that crown preparation and then start doing your impression. All right. So perforated trays are always more acceptable than non-perforated trays. Now, gingival displacement, or what do we know as cord retraction, as we call it. What are the different types that we use? We use retraction cord. We use electrocautery or lasers. You can use rotative, burrs which cause gingival curettage, which I do not recommend at all. Then you have retraction paste, but retraction paste by themselves don't really do the job very well. So what is my go-to standard? So this is a retraction paste. What is my go-to standard? My retraction cord. Now, depending on the biotype of the tissue, whether it's thin or thick, I choose the thickness of my cord. So it starts at 0, 0, 0, 1, 2. You have up to 3 and 4, and you will notice that I hardly use my 3s and 4s. So if you have a single if you have something like a laminate or a veneer for the anterior, a single cord may be enough. For the posteriors, these are just examples. These are not guidelines. Please, there is no thumb rule. These are just examples. This is just a guideline for you to determine how much or which cord I should use for which area. So this is my range of cords that I always have in my clinic. So I mainly am using the 00 or the 0, and sometimes the 0 and the 1. As you can see, that number 2 cord is pretty old, and luckily they don't have a shelf life or they don't have an expiry.
Akhil sir, till you're having your small water break, there are, I believe, a couple of other screens that are opened. That is the reason there is a little overlap coming on your presentation. Can you just close all your other windows and only the presentation should be?
One sec. What are the other presentations? I don't have anything here which is.
But it's looking good at the screen, I guess. PC on laptop, it's looking great.
Okay, fair enough. You can proceed ahead then. Yeah.
No, please, we need to what we call get this sorted. Why is it showing like that?
No, then it must be right. If Himanshu said it, please go ahead, sir. Please go ahead. It must be right.
Go ahead.
Yeah.
All right, if you say so.
Oh, there is something.
There is.
Yeah, now it's okay.
Now it's okay?
Yeah.
Thank God. We are all getting used to this online bit, all making our mistakes. And that's how we learn. I think that's the way, a fantastic message to take home that I have done this for the 4th time, probably 4th or 5th time that I'm doing a webinar and still learning. So every day is a learning curve. Thank you, Sagar. Thank you, Himanshu, for helping me out with that. All right. So there we are, back to our cords. Now, if you place a single cord, if say, imagine, this is your tooth that you prepared, and this is your soft tissue, and you've placed a single cord here, right? You remove that cord, and when you place your impressioning material, the sheer force of that consistency is going to press onto this tissue and make this thing collapse. And suddenly you will notice that all that cord that you placed there and did that retraction is lost. So single cord technique for me doesn't work. Very rarely, if I'm using a single cord, I will leave it in place and I will not remove it. Okay, and that would be mainly for my anteriors if I have done some very fine veneer preps. If I have done a double cord technique, that means the first cord is thinner, smaller, then you have a bigger cord on it. All right, now you remove that second cord prior to taking your impression. So you remove that cord, you put in your light body, and then you put your heavy body over it. That means your putty in your tray, and that's how you take your impression. How many people would agree that we can use electrocautery or lasers for retraction? If there are periodontists watching this, they're not going to be very happy if I say that I would use an electrocautery or laser for doing my retraction, because you somewhere damage or create some discrepancy with the periodontal tissue. But if you have subcrestal margins, deep class 2 cases, you've just done, you don't have a choice. There is no way that unless you do bone remodeling there, that whole biological width is going to readjust itself to this new position of your margin. You at that time may need the help of a cautery or a laser to pick up that margin. But please do pick up the margin. Never leave a margin of a crown preparation on any restorative material. It has to always be on tooth structure only. So again, a take home for you guys, always on tooth structure. If you sometimes need to do scalloping or gingival aesthetics, where you just have to do a little bit of gingivectomy, not crown lengthening, then you would use a cautery sometimes or a laser. And please note that these things can recess. Now, look at this scenario here. I have, 2 crowns really short. There was inflamed tissue all over. I have used a cautery, right? Post my crown preps. And this is an impression which I took years back. Years meaning years back. Must be a good 15 to 18 years ago. All right. But when you look at this, you must be thinking, wow, this is good. And I'll show you later that this is not a good impression. But anyway, it's a place where you can use the cockpit. Now, setting shrinkage. When you see an impression like this, okay, it's a full mouth impression, right? I have done a putty and a wash technique where you see the light body as well as the heavy body, which is your base. And you notice most of my margins are good. Please don't look at certain areas. We were still, developing this particular tooth. You will see it say, oh, it's wrong there. It's not wrong there. We were developing a certain kind of restoration that goes and fits into that area. But this is your scenario here. Let's consider that everything is good, preps are good, and this is my scenario. Would you consider that this is a fantastically good impression? Probably not. The reason I say no is because that when I leave this material standing, all right, one second. When I leave this material, let's go back, standing on the desk, what's going to happen? I told you that the shrinkage continues even as it is lying on the table. And where will the shrinkage occur? Towards the mass of the material. That means all this is going to start shrinking towards this. Now, we have a long span bridge here, right? Just imagine, this is exaggerated, but this is something for you to take home. This is lying on your bench and it is shrinking towards this mass here, right? What's going to happen? This, when it reaches the lab, might probably end up like this. Please understand this is exaggerated. It'll be in microns when we are talking clinically, right? But have you had scenarios where you have a 4-unit bridge and suddenly the mesial abutment is seating, but the distal abutment is not seating, and then either you end up touching that tooth, prepping it a little bit, or you end up running your burr within that abutment, the distal abutment, the crown, and suddenly it goes into place. Why should you be doing that? It should fit in perfectly. So this is one of the reasons why you could have an issue like that. Many a times I've seen people, like I said, I used to do it. If I push my impression harder towards the tooth, I'm going to get a better impression. All right. So here I'm trying to do a mandibular 3-unit bridge somewhere here. And here I put the tray in and I'm leaning on to my entire, tray. And what's going to happen? The mandible, as it opens, as it goes down, it flexes. Meaning what happens? The mandible contracts like this. So suddenly you have a 4-unit, 3-unit bridge again that is not seating because you recorded the mandible in this position, but actually in the patient's mouth, it's in this position. I'm again exaggerating, my friends, but you understand the small, stupid mistakes that we make in our day-to-day practice without even realizing it. Once you place your tray in, you have to make sure that you ask the patient to close where you just have enough space for your 2 fingers to hold the tray in position, which means you need 20 mm of space beyond which the mandible flexes, right? We don't want that too. So now you've put all your trays in. How are you going to remove it? Is there a technique in removing it, or you just go 1, 2, 3, boom? No, you don't do that. There is a technique also in removing this. So let me see if I can get these here. Yeah. So when you have a maxillary arch, all right, if this is your maxillary arch, and let us assume that I have prepped teeth on my upper right side. So you realize, I'm going to again show it to you more diagrammatically, is that you see that the teeth will be in this position. Why? Because they're following the bone line, which is going to be like this. My teeth are prepped on this side. This side, the teeth are like this. So now which side will I pull first? Think logically, and you will suddenly realize that I need to pull this side out first because my material, which is here, is going to flex out. And because of the elasticity of the material, it will come back. And then I can just, so this side where my preps are, they don't distort. So there is also a technique in removal of the tray, right? Now, if you have the mandibular arch, teeth are going to converge. They're not going to diverge because that's how they follow. So again, if I have preps done on my right side here, how will I remove now? Now in the mandibular arch, I will first pull out from the mandible, the side which I have done my preps on, and then I twist it a little and pull it out from the non-prep side. I hope everybody is getting this. If not, I'm always free to answer these questions later on. Sagar will give you all my information later. For anterior preps, the teeth are going to be like this, right? And how would you pull them out? So you release from the posterior and then you pull your tray out like this. For your mandibular preps, it doesn't really matter because they're almost straight. Always break the seal. The seal is normally around the cheek here for the maxillary arch. That is the biggest problem. So what do you do? What do you do? So you take compressed air, your 3-way syringe, put it all there, the seal breaks, you will get your. Now, you remember that image that I showed you on the setting reaction. How do you avoid that huge mass in the center of your tray? You avoid it by even using mandibular trays for the maxillary arch. You don't need the palate. You only need the palate if you're making a complete denture or a cast partial where you need the palate for support. Yeah, so that's how I do it. Now, would I make a custom tray or would I make a stock tray? I mean, would I use a custom tray or would I, use a stock tray? My preference is definitely towards custom trays, but today, as we all know, a custom tray is going to cost you because the lab is going to charge you for it. So I'm going to show you a technique of how you use your stock tray and make a custom tray out of it. Materials. You have polymethyl methacrate to make your custom tray, which is what the lab will charge you. It's for a complete denture, or even I make them for my regular crown and bridge dentistry. You can use photocured bisacrylic material. You can use putty. Now I'll show you the technique which I have shown you here. Now, how do you get a custom tray made for a crown and bridge, what we call scenario? See, suppose these are your 2 teeth that you're going to prep, and you need to pick up an impression for that. You need that the tray does not go and touch the teeth. Once it touches the cusp, the entire impression is a wrong impression. It is warped. It's already distorted. So what we do is we mark these areas. Can you see these 3 areas that I have marked? These are non-functional cusps on the same arch. Not functional cusps, because functional cusps help in the occlusion or the bite. So when you pour the model and then you have the opposing arch, those are very important for you. So if you put these rest seats on them, that's not a good idea. Now what you do is you use spacer wax. You put spacer wax around the entire this, and then you take the back end of your cover and you just scoop this out. So what happens? That cast is seen through. Now when you put your acrylic material, whichever it is, your methyl methacrylate or your bis photocure or whatever that you use, you will find that they go into the windows. Why is this not? And I just realized, I think there are 2 slides working together. Now I realize why you guys were.
No, it's not 2 slides. The previous slide is not getting down and new one.
Yeah, that is exactly what I was trying to convey.
I realized.
Somehow we were not able to convey that to you exactly, so we just let it go on.
Now you all see if this.
Now it's okay.
It's perfect, right?
No, not exactly.
No.
But,
No.
Wait, let me. Better now?
Matter is clear, but thoda sa problem hota hai.
Okay, chalo, I think I'll just continue. I don't want to hold people up. Yeah. So
Yes.
What would you use as viscostatic agents? Sometimes you have that bleeding around teeth. These are all the different ones in the material available in the market. Be aware of this particular one because this stains. All right, it's ferric sulfate, so it sometimes leaves a stain on your this. So you have to be careful of that. My favorite one that I use is your local anesthetic with adrenaline. For me, that works the best. I inject a little in that area. Any which way, if I want to do cord retraction, I may or may not need to inject. And then, that injection helps me with both things. It helps me as a, viscostatic agent as well as numbing the patient. Different techniques and how I use them. All right. Impression, you have one stage, you have two stage, right? So you have a putty and a wash. You can do it together. That means you mix your putty, load it in the tray, you take the light body, you inject it in the patient's mouth, right? And you put your putty into the patient's mouth. Fast, good, pretty decent. If you can control the moisture in that area beautifully, then that is the technique I would like to use. Then if I have multiple teeth, and I'm not very sure that I'm going to get my light body around all of them in one shot before my putty sets, then I would do a two-stage, all right? Now, again, the heavy body and wash is, heavy body is just a consistency. So similar technique to putty and wash, the same way it's the heavy body and wash. And your medium body, like I told you, I like to use it for all my, complete dentures and my, how would I say it, my cast partial cases. Now, in a two-stage, say, for example, I am going to see if I can increase this window size. I can't. Anyway, if you guys can see this, this is an index I have made of my own mouth. And this is the putty index, right, that I have made. And now what do you do before doing your light body? So this is the two-stage technique that I'm trying to show you. Now see these areas here, these are all going to go over undercuts, right? Do I need this? No. So I'm going to take something like a, putty cutter like this, and I'm going to cut this away. Right? So I'm going to try and show you all that. I'm going to cut all this away. So give me a minute. I'm going to show you exactly what I have done. So all the areas that you don't require and are going into the undercut in the patient's mouth, you see now, I have cut that away. This will still fit beautifully in the patient's mouth. But you know what is the biggest problem here? The biggest problem here are these are going to all end up engaging and not letting this putty sit down, because again, that is an undercut area. So what I do is I take a number 15 blade and I just knock this away. Can you see what I am doing? Sagar, is it clear? Please help me with this, because I am
it is relatively
really holding
clear.
the relatively,
It is relatively
clear.
You're trying the best possible.
Yeah. I'm just quickly going to show you what I do and how I remove all those undercut areas. Take a nice good number 15 blade, do that. And then always make sure that you reseat this impression in the patient's mouth. Now, if you see this side, I've already done it on this side. Can you all see this? Sagar, is it clear?
Yes,
Sagar,
sir. Yes, sir. Yes, sir. Yes,
yeah?
sir.
So you see now how I've removed the undercuts. I'm not doing the entire impression because I'm, with time constraints, I want to, go ahead with it. Then now what I would do in that impression, I would directly inject light body and put it in my patient's mouth. Of course, make sure that you dry the tooth, that is, you're going to, the prepared tooth. You make sure that you pulled out the second cord, and all of that remains the same. You will see, you will find your impressions start coming. It takes a little longer to do this, but they are more, easier to manage. So putty wash. Now let me tell you, how do I make a stock tray into a custom tray? So say, for example, again, I have these two teeth that I am going to prep. What have I done here? Window, window, window. They are non-functional cuts to which I put a spacer wax. And you see, you can actually see those markings through that spacer wax. So I take the back end of my cover and I just scoop them out. All right. You will be able to see this better now, right? Yeah. And now over this, I take a whole tray mixed with putty and I plonk it on. Look at this. When it comes up, you have exact space for your light body to flow through this area. So don't use gelatin paper and all of that to create that space for your light body, because they are not accurate. I would heat this spacer wax and literally push it into the nuances of this impression, and then you have a customized stock tray to use, right? This is for a full arch impression where like I showed you, I've just taken a direct putty index first. I was not confident that I would get every margin on all my teeth perfectly recorded here. So I've taken a custom, what we call tray, a regular stock tray, taken putty, and I've just made an index here, to which I reline with light body. Now you see automatically the fit, everything just comes out beautifully, right? You can do simultaneously, but you will see in this scenario, if you're doing it simultaneously, I'm going to show you a small video. So this is a case where, patient, I'm not going to talk about the entire case. I'll just talk about the impressioning is where, 6 units had to be made, and then we are going to make a cast partial. It was like a, overdenture kind of scenario where we were doing what we are doing here. So now look at this scenario here. So you see, I start with placing my cord. Cord's placement always has to be done from the interdental area. You notice I'm not using a cord packer here because I don't like serrated cord packers. Serrated cord packers, when you slip, you actually injure the tissue, causing the patient to bleed there. Once you bleed there, Now this patient is a completely periodontally compromised case, all right? And you notice he will also bleed during the what we call impressioning procedure. But how you can control it and how you can take care of these things whilst you're doing the impressioning is what I want to show you. This is not a classic regular case. It's a difficult case. But the idea I'm showing you or sharing this with you is because so that you all will be able to see it. All right, now I am going to slightly run this a little fast because I don't want to hold on to this. You see how very gently I go through the entire tooth, coming back into the same interdental area. Always leave a little excess so you can cut it away. And now this little bit, you tuck it in. This is my first cord, not my second cord, right? You saw the patient was oozing a little bit of blood there. What did I use here? I'm using local anesthetic with adrenaline. And you see the blanching that it is creating there. That blanching causes vasoconstriction. Vasoconstriction causes blood to stop. Yeah. Blow air on it, keep it dry. Now I'm going to the other side. Yeah. Start again interdentally, packing my cord in, again in the interdental area. Coming back, you notice this side has got a little bit more of an ooze. That means there is something on the lingual which is causing this to happen. So I tried to clean it. And now you'll see, notice that as I go again, the same technique, I'm injecting to cause that vasoconstriction to happen. Once the vasoconstriction happens, I still find here, I have ended up using a cautery. You see that little inflamed tissue which was not stopping to bleed. I have used a cautery. You can use a cautery or a laser, but please don't go to bone. Biological width. Please understand, biological width is one of the most important things for a good impression. And then your prosthesis remaining at that healthy state of tissue. This is my second cord. When I'm placing my second cord, always again starting from the interdental area, but a little away from where I ended my first cord, because I don't want that when I pull my second cord out, the first cord also comes out, right? Very gentle pressure. You will find that the second cord takes a little longer to seat in, but you notice, you can see how beautifully that retraction is occurring. And I can now clearly see the margin of my preparation. Yeah. As I am going through that, I'm going to go through quickly. Here, that excess bit, I'm not going to cut away totally. Why? Because I want to use that as a tag to which I can pick on when I am ready to do my impression. And you shall see it very soon. So there goes my second cord on the second tooth. And of course, as you can see, I have done all the cord retraction for the other 4 teeth also. And now I'm ready to take my impression. Tray, and I pull my second cord out. As you can see, all cords coming out. Yeah, very gently. The bleeding is controlled, but on the left-hand side, as you see, there is a little bit of an ooze. And this video was done by the Indian Spider-Man, because as you can see, it is done completely upside down, right? So the Indian Spider-Man is me. So we remove all the blood, we dry the area. And the trick here is when you inject your light body, always make sure that your tip is within the light body and pushing it. Never pull it, because if you pull it, you will get an air bubble. You notice my tip is always within the light body and it's pushing it forward. Now 110% in this area over here, I'm going to have blood there. So I take my 3-way syringe and I gently blow air on it. And we notice the areas which are wet or which had that saliva, blood, whatever fluids underneath it, the light body will leave that area. So you re-dry that area, again inject, and then you will load your putty in it. This is the reason why I put my putty in the fridge, sometimes for cases like this. So what happens, I have more working time. Setting time remains the same. Then I've loaded light body all over. One more last blast of air, wherever I need to retouch up, and there goes my putty in place and impression in the patient's mouth. This is how it comes out. So you see what I'm saying? If you follow certain techniques that I'm showing you here, you will start getting good impressions anyway. Workability. Automix devices always help me improve my workability. And I will show you this also again in a video when a little later, when I'm showing you another technique of impressioning, which is known as the dual arch technique, right? If you use these automixes, I want you all to notice this. If you do around 4 crowns a day, if you use the automix, the hours saved over a year is 37, and over 10 years is 370. Can you buy time? I can't buy time. Time is always lost, right? You can never buy time. But if I give you something, by investing into it, I can buy time. Time is priceless. So I think investing into these kind of machines helps us. Now just assume that you are doing a double step putty technique and you're doing a single step with this. The amount, assuming a doctor does 2-step impressioning in a day, 2, you end up using 12 hours and you end up saving 300 per year. Okay, that's a lot of time saved. And that for me, time saved is money earned. All right, I can do one more case, I can do something else, I can go out. Not at the moment, I'm in lockdown, but yeah, I can go out, I can probably meet friends, I can do something for myself. Now, dual arch technique. When you're doing a single crown, which we end up doing in many cases, single crown on the posteriors, not anteriors, only posteriors, you can use the dual arch technique. All right. Now, what are the indications and contraindications? It can be used only for maximum of 2 prepared teeth. And the prepared tooth should not be the last tooth. Okay. So you should have unprepared stops anterior and posterior to the prepared teeth. So you can do a 5 and a 6, but you can't do 7 or 6 and a 7, because the 7 is actually a stop. So you can't use it on 7. So 5 and a 6, or if you have an 8, which is in occlusion, then you can do a 6 and a 7, right? Only with patients that have an existing anterior guidance. Suppose they don't have a guidance, then you can't use this technique again. All right. And this technique works beautifully for gaggers. Believe me, if you have to take an impression for a gagger and you have to put a whole tray in it, you literally end up seeing what they've had for lunch or breakfast on that day. You don't want to do that. Whereas this is a technique where you ask them to close their mouth. When they close their mouth, how will they gag? The whole gagging reflex only goes away. All right. But the trick here is you have to use rigid metal trays. You cannot use plastic trays, and the material has to have a good rigidity. Clinical simplicity, accurate recording of MIP, because you're recording the patient in MIP. You ask the patient to go bite. Please bite on your back teeth. Always practice it with your patient a couple of times before you put that final material in, because many a times they tend to, when you tell them to bite, bite on your back teeth, they go, These are the positions that they give you, all right? So you don't want any of those. You want it in MIP. So always I run it through with my patients a couple of times before I do it. Of course, the biggest advantage that we have, there is less material used, all right? And closed tray technique. So say this is a tooth that I have prepared, all right? You check for clearance, you do check for, there's my cord retraction in there. That's my impression. So you have the blue, which is the light body. You have the yellow, which is the heavy body. And then this is the metal tray, which goes into place. So you can use this, or I can show you the same. So you have what? The prepared tooth on one side. You have the opposing arch, which is on the other side in the same this. And you also have the bite. You have done 3 things with one impression. Yeah. And that's how the lab fabricates the model, sends you the crown, boom, in the patient's mouth. This is how it goes in. So I'll show you a technique where we did a video for the company 3M, where I've used polyether. Instead of now, I've again stopped using too many materials. I use one material, so that's polyether. That's a crown that I had prepared. Yeah. Today, don't use a scaler. Not recommended. Aerosol. All right. Inject again a little bit of ooze. I'm going to place my cords in. So you either do that, or you can use something like this. It's a Profi brush, Profi paste. Remove all the residual cement that you might have there. That is your temporary provisional cement that you have there. Now you notice here I'm using a 00. On a premolar, I'm using a 00. So it all depends, tissue type, biotype of your tissue, what you are up against, what cord you need to use. All right. So there goes my cord retraction. Tucking it in beautifully. The first cord has to be completely tucked in. The second cord, this is the 0. And you see again starting interdentally, going right around the tooth, coming back. And here, a good tip, a good technique that I would like to share with you all here is, you noticed how I went back and I retucked it back in. So sometimes, you need that little extra retraction in the interdental area. Don't cut it away. Just turn it around and reuse the same cord. And that's how I get that little extra retraction that I need. Right? Now, what am I checking? I'm checking for clearance. And I'm also making the patient go through that bite. That's my adhesive. This is my tray. This is the tray that I have designed. And if you all want, I can give you all the connect to where you can buy these from. These are reusable, autoclavable. That little mesh that you saw on which I'm applying the adhesive is, you throw it away and buy them really cheap. They don't cost you even 10 paise a piece. So that's your base and catalyst. That is the Pentamix machine. That's how you load your cartridge. All right, that's the cartridge. Loading the cartridge comes with, this is your catalyst. So you make sure that these notches match totally, perfectly into place. Now this is something which I don't do. This is my team does this for me. They've loaded it. That's your mixing tip, which you attach to your penta. Always bleed, always bleed. This is something which I would like to again bring to your notices. Whichever mixing tip that you use, whether it's for your light body, you use it for anything, sometimes we even use it for cement, certain cements which are always bleed, because many a times the base and the catalyst may have not totally mixed. And you will notice in this, you will see that the color of the polyether was also, where did it go? It was not totally, the color that you would want to see in the first shot. See, it's yellow and it slowly gets into the dark green later, because that's when the entire thing is mixing. Always load your syringe from the back and never from the front, because you don't want the back pressure. This is like light body. I'm injecting light body onto the tooth, kept it there. Now this is a little ideal case, so you don't see all that blood and all that oozing. Blow a little air, make sure it flows. Why do I blow air? Blowing air induces the thixotropic property of my material. Under pressure, the material flows, and that's how it's going to record my accuracy. Yeah, I'm going to reapply my light body there. In this case, it's polyether. So polyether is a monophasic material. So we can use it both as a light body as well as the base. Then I inject the rest onto my adjacent teeth, making sure that I have covered all my contacts and all the critical area that I need in the patient's mouth. Now you see how my clinical staff just does it. Press a button, material is being loaded, hand it to me, given to me. I take this, I put it in the patient's mouth, ask the patient to bite, or else right now we would be taking putty and mixing it. The biggest problem that I have with putty being mixed is I've seen many a times people mixing it without gloves. Now, when they tell me, no, gloves interact with the putty and it retards the setting or it hampers the setting. Gloves don't retard it, all right? It's the powder on that latex glove which actually hampers the setting of the material. So if you're using powder-free gloves or nitrile gloves, you're totally safe, all right? So please wear gloves. Imagine, you have those dirty nails from whoever's practice and everything gets incorporated into that putty. I mean, hygiene is something which I am a little very fussed about. So, and especially in times like this, we need to really take care of that. So use gloves. In this case, I don't need any of that. It just goes in. There is no mixing. It's a machine doing it clean and beautiful. That's how the impression is. You see how beautifully I picked up the margin. Here is the opposing arch. Then I clean that area. Don't forget to remove that first cord that you placed in. There has been a time, a couple of times where I've forgotten it. It just creates a lot of irritation to the patient. All right. So you don't want to do it. Make sure you remember it. I also tell my team to remind me sometimes, when you've got a good impression, you're on a high and you want to, just let the patient go. You cement the provisional and you send the patient away. Cleaning all the excess, temporary cement, and boom. Faulty impressions. I've talked about all the techniques of how you can get the best impressioning, but I have also got faulty impressions and I'm going to share them with you. These are my impressions, they're nobody else's. These are ones that I have done. Remember, I showed you this case and I said this was a faulty impression. What is faulty in this? The margins are perfect, but there is no light body across this area here. Light body has to be injected all across the putty. Only then you get accuracy, because when you're looking at occluding these two, what if there is a discrepancy here? That will never occlude. Your models will rock, and according to which your crowns will not fit. I removed this impression from the patient's mouth. My impression, nobody else's. You notice this? There's an exposed tray. When a tray is exposed so close to your margin, that material, that impression is distorted. Look at this. You have tray exposure. I have pushed it so hard in that it is touched the tray. Also notice no light body around here. These are faulty impressions. Let's look at this impression here. I look at this impression, I send it to the lab. Boom. What is this here? It's a drag. We call it a drag. You cannot have that. What happened here? This is when the heavy body and the light body, I was doing a simultaneous impression. The heavy body had already started setting. Certain parts of our country, there is sometimes no electricity and it becomes very hot. I wanted to get that impression that day because I had traveled to that clinic to pick up that impression. So I made that rush. Okay, let me do the impression. I don't care. And I injected light body. My associate had mixed the putty, given it to me. And when I pushed it in, the light body had already half set before my putty was going in. So you see all these drags that you see here. Say for example, this I have picked up pretty well, but the rest, so these drags are because of wrong setting times of two different materials. These are all drags. You can't use this material. You can't use this impression. Now look at this impression here. When I pulled it out of the patient's mouth, it has tone here. Can you see that? I can't use it. These have to be redone. You see, the tear goes all the way onto the surface. This was an impression for veneers, mandibular veneers. No, can't use. Many a times the lab technician tells you, Doctor Saab, thoda impression is not, 100%. Can you redo it? You just make me the crown. I'll fit it in. Don't worry. I don't have time for doing a re-impression. We never listen to them, but we expect every crown of theirs to fit, which is like, I don't understand how. But anyway, so if you see this impression here, and he poured it, I thought I had got it perfect. He poured it and then he calls me up and says, Doc, I think you need to redo it. Look at this. There is no accuracy in the margin at all, both sides. If I ask him to trim it and make me a 3-unit bridge, he will make it. But will it fit perfectly? No. Will that, what we call the probe test that I use for checking for my margins, will it ever hold good on this case? Never. All right. So you repeat these. When you get impressions back from your lab telling you to repeat, please repeat. Now look at this impression here. You see this? Again, the same thing. The tray has touched where my margin is. Repeat the impression, right? So these are faulty impressions. You should be able to pick your faulty impressions, and you should also be able to accept it. When you accept something, already for me, you have learned a lot. For me, that is it. So many a times, you've taken the impression, I'm literally hanging off till the crown comes back from the lab, and I make sure that I'm sitting it down in my patient's mouth. Now let's go to some clinical cases. So I'll show you all certain clinical cases. This was this was my first full mouth rehab case that I did in my life. And this lady was my patient. And as you can see, when she smiles, you have a lot of decay everywhere. She was a chronic smoker and a Coca-Cola drinker, right? So acid along with dryness in the mouth had caused all this to happen. So we decide now we don't know what to do. How do we connect this area here? That's a tricky part. Here I'm going to give all single teeth, single units, but how do I connect this area? We shall talk about it. So I do my preps. But after I've done my preps, remember I told you this is my first case. Yeah, I made my provisionals. I put them in. Now my professor tells me, Akhil, we need to pick this up and send it to the lab. You need a full arch impression. So I was scared of doing a full arch impression. I never knew if I could pick up all the margins from my molar here to my molar here perfectly. So what we ended up doing was I started doing partial impressions of 2, sometimes 3 teeth, which I was comfortable. Cord placement, inject, light body, pickup impression. Then we made these singular dies, right? To which we made these copings. These are pattern resin or Duralay copings, right? And this is a customized tray that we will use for this case. All these copings are so precisely made. They are like your metal trial that you do, the metal coping trial that you do, or your zirconia coping trial that you would do. And then these go onto the patient's mouth. You can see how beautifully they fit. Every margin is done perfectly. They have an undercut here. As you can see, it is like this. So light body or heavy body gets into that, and then you pick it up. So you see that step that we've created, they don't look like teeth. They're just like caps. They sit on it. Adhesive, your heavy body, light body you inject around them just in case you missed out, and the heavy body in the tray, and you pick the impression up. This is known as a pick-up impression, right? The same thing for the lower arch. The front 3 teeth, we did only composite work. The others these were 2 implants, so we wanted a pickup for that too. Same thing, we made copings for the existing teeth, and these were the pickups for the implants. These were the 3i implants in those days. This is your, custom tray. You put in your pickups in the patient's mouth. Adhesive, light body, heavy body, boom. Now, what do you do with all these pickups, these impressions, right? How do you make a model out of it? So all those single dies, they go in like a jigsaw puzzle. They all fit in, right? Once you fit that in, you pour the base up and it becomes a model. Yeah. Now, what we did for the upper arch, remember I told you that long span. So we made a 3-unit bridge here, 1, 2, 3. We put a semi-precision attachment here, semi-precision attachment. And then to that, we gave again a 3-unit bridge here. So that thing was broken between the 2. You have a 3-unit bridge for the mandibular implants, and these are all single teeth. You notice here, this is an all ceramic crown. In those days, Vita in ceram was the in thing, and that was now probably totally obsolete today. Vita in ceram was the first crown that came as the all ceramic crown, and we've used that. The others are PFMs. Yeah, that's how they look in the patient's mouth. Upper arch, lower arch, screw retained bridge. And that's how we finished her case. These are actually slides that I had taken in those days, which I have converted to digital. So that's why you see a little discrepancy in the colors. But other than that, this is how we finished. This was how we started. This is how we ended. All I wanted to show you here was a different technique of impressioning. Yeah. Now we'll discuss central incisors. I know a lot of people love talking about central incisors, but this is one patient that walked into my practice. As you can see, this entire tooth here is a buildup of composite. It's just a blob of composite somebody has built up, shaped, nicely polished. Patient was lasting through. So I took an X-ray. This was an endodontically treated teeth on which just composite was done. And he came to me for a crown. He says, "Doc, I've heard that you do good work." Not really, but anyway. So I've done my shade matching. I've done my crown prep. Now, when you see a stump with discoloration like this, the choice of your all ceramic crown should vary. You can't do a crown which is translucent. You have to have a crown which is slightly opaque to hide that shade underneath. Yeah. So if you do something like an Emax or a lithium disilicate on this, you're going to have the discoloration showing through. So your choice here will be zirconia. And again, in zirconia, your choice will not be the translucent type. It will be more on the opaque type because you want to hide it, right? But only thing over here, my suggestion is you make a zirconia coping and then you layer the entire crown on top. Yeah. So this is my first cord technique. So put my cords in. This is my light body in place. Now see, this is how I load my upper tray. I have putty. You notice I'm using a mandibular tray. I'm not using a maxillary tray. I have putty on which I have a light body. And on that, this is how I'm going to place it in the patient's mouth. And you notice how I picked up the entire margin here. Wherever the putty is, do I need accuracy there? No, because I need any which way. If you realize your technician applies a dye spacer there. If you're doing CAD/CAM dentistry, you will find that on ExoCAD, they will input a spacer as per the doctor's requirement according to which cement they are using, because each cement has a different thickness that we use. And that's how we finished this case. All right, so choice of material here was it. Now let's look at another case. All right, this is how this patient walked into my practice. Single 1-1, old crown, doesn't like the look of it. I said, all right, let me remove that crown. When I remove the crown, I know this is also endodontically treated. So I asked him, how many times has been done? It says 3-4 times people have tried. Now, how is it? Good. If it's good, I don't want to touch the endo. All right. I'm going to do the restorative part. But all this area which is dark is what I like to remove. So I take a caries detector dye and I apply on the inside, and everything which is decayed, which is infected and not just affected, I will scrape away, I will remove, and then I put in temporary filling like this and I send the patient away. But you see the canal, it's really broad, really widened up because of all the multiple root canals done in there, plus all that infected dentine that I removed from within the canal. Once I've done that, you notice the shade also tends to lighten because all the dark areas comes up, and all the thin biotype tissue which you have here, it tends to lighten and does not tend to show through. Once I did that, either I make a cast post and core here, which will probably weaken the tooth. I want to use a material which will add to the strength of this tooth. So I like to bond here, and then of course follow the concept of ferrule, and the ferrule that I like to follow is this one and not that one, right? Now, this was the thesis that I had done, where if you don't have a ferrule on a tooth, this is the kind of stress that you see on the palatal margin, and also the stress you see on the buccal ceramic there, right? But if you put a 2 mm ferrule, You see how much the stresses reduce. So this is before and this is after the ferrule placed over there. So I'm going to give a ferrule to this patient, and I'm using fiber pore.
Sagar sir, you there?
Lost Akil sir, I believe, for a minute. We need to just contact him. Is there? I'll just try and call him for it. Just give me a minute.
Yeah.
I'm unable to get through him. Akil sir, can you hear me? Hello,
No, no, he's not
Akil
there.
sir, can you hear me?
I'm trying to stop his sharing even, and I believe it's not happening.
We've just conveyed the message to Dr. Akil Reshamwala. He's
He's logged in
kind of.
now.
We
I can see
apologize
him.
for the technical glitch. He should be back with us very
I'm
soon.
back on.
He's there.
Kindly be patient.
He's there. He's there.
I'm back again. Sorry.
Sir, you need to start screen sharing again. It's stuck over here.
Okay.
Himanshu sir, can you hear me?
Yes, sir. Perfect.
Can you all see? Are
Yes.
we good?
Yeah, good to go.
Okay. Sorry about that. So then I've finished my prep, polished it. Like I tell you, you will be able to see it better in this image here. That yeah, it's polished, ready to go. Then I had taken a quick alginate impression before I started doing the prep. So that is my template for making my provisioning. I inject some ProTemp in it, put it in the patient's mouth, and that's how it comes out in the patient's mouth. All this flash needs to be removed. I've seen a lot of people using burrs to remove this flash. Please don't use it, because a burr tends to ditch in, it tends to cut through that material. Use something like a Softlex disc, a sandpaper disc, which actually will take the shape of the contour and give you a beautiful, that's how you send this patient away. Patient goes home, you see the tissue is so much better. Also, I want you to notice that that whole blue halo that this patient had before here is reducing, right? Now, I have this ready for impressioning. First cord in, second cord in, pull the second cord out, light body goes into that area, impression taken. Now shade matching is being done. Once the shade matching is done, you see this is ready for cementation. Moment I put this in and I look at it and I said, do you really like this? I said, no, I don't like it. The value is off. I mean, the tooth is too bright. Now my technician, being an expert technician, has created this, fantastic, characterization here. Even his line angles, as you can see, are beautiful. Everything is beautiful on that, but the value is off. So this is a picture that I sent to my lab, and then he finishes it and he sends it to me like this. Now here, the material used for my crown is a lithium disilicate. It's an Emax. Yeah. So you see how beautifully the tissue, the stippling, you see how well it is matched. So again, choice of material, where you use what. Today, I bought this 2 years back, and this is a case from 2 years back, where I use digital scanning for my impressioning. Okay, and in today's time, again, like COVID, where you take care of sterilization, this is a fantastic way to do impressioning. Today, most of your impressions are also scanned by lab technicians, because they then import it and use an ExoCAD to fabricate your prosthesis, especially for single crowns, 3-unit bridges. They are using this technique. So this is a very quick video to show you. This is the retraction paste. So here I have only placed one cord, and then I have used a retraction paste as my second cord. Now what this retraction paste does is it causes retraction. Along with it, it also stops bleeding if there is any. It has the property of an astringent. Yeah, that's why it's called an astringent retraction paste. This is the scan that I am taking of the opposing arch. That is the lower arch. And even in digital dentistry, they will tell you that you need to make sure that you only take quadrant scans rather than full scans, because quadrant scans are more accurate than a full scan. Yeah. Sagar, are we there?
Yes, you're on. Yes.
Right? Yeah, we're on, right? So because I just sometimes when with these glitches, I want to make sure. This is a quick. Yeah, so that was your retraction paste, which I have got in there. I'm going to just quickly run through this one. So then I cut that retraction paste out, and then I use a property. As you can see, I've cleaned it, even within the mouth. You see my first cord is still in there. You can appreciate the margins around this area. And then what I do is there is a what we call option here to zoom. And once you zoom, you can see how beautifully that same scanner is picking up the margins, and you can actually appreciate the margins very clearly on this scan right here. And we cut away all the excess, right? You mark the tooth that you're going to use for your restoration. And then check this. This is your bite. You ask the patient to bite, you put the scanner in the mouth, and you just scan, and the scanner picks the upper and the lower jaw and puts it together. It just is a beauty. I mean, material cost is zero, except for the investment towards the scanner. Yeah, it's a little bit right now, but it's 110% going to drop over the years. Okay. So this shows you the clearance. It shows you if you're good. So all my contact areas are seen in the red. Wherever I have good clearance is the green, and all this. And this is then what goes to the lab. You send this. Here I am doing shade matching. As you can see, you can actually, you take a cursor and move it on different parts of the tooth, and it tells you which shade it is. The same the lab can do at his end. So no more shade matching where we take that tab, and it's pretty much redundant for me. I use this, and believe me, I get fantastic. 3Shapes is the only scanner which gives you this shade matching option. Yeah. You specify the date that you want it. Send it across. This is processing the scans. Once the scans are processed, the crown comes back like this. Believe me, my friends, there's only a crown that comes back. There is no model. There's the first time as a prosthodontist, when I just saw a crown and in a small little dibby, I was like in a state of shock. I put it in there, I check it, beautiful. Everything's perfect. You saw how the end result was right there. Quick case to show you. People tell me that, normally when you do a single crown, it's very easy to do a provisional. But if you're doing a 3-unit bridge, how do you do it? I'm going to quickly show you this case. This patient came to me years ago for a 3-unit bridge. Endos were done, as you can see the reason why. I'm not going to go into the treatment planning of this case. But what we did on the day I was prepping is that I quickly put some, temporary restorative material in that area and took a quick alginate impression with a half tray, like a half tray here in alginate, kept it aside, and then I did my preps. My preps were done. The core was built up later. And then all I do was a number 15 blade, and I joined the distal of the premolar and the mesial of the molar, scoop out that little bit of alginate, inject Protemp into it, and put it into the patient's mouth. And that's how my 3-unit bridge comes out as a provisional. Another case, patient came to me like this, "Doc, can you do something?" I said, "See, there's a lot of composite work done here for you, and quite a bit. I'm going to move this a little here, if you all don't mind." Yeah. So you see a lot of composite work. I said, "See, let me, I'll have to remove all the old composite. I can see a lot of bond failure happening here. A lot of things not, 100%. So we do a quick, mock-up outside the patient's mouth. I take an index, and then I want to do a trial run. So I remove, roughly all the composite which I see is wrong. I also apply, your caries detector dye and remove all of that. And I say, let's do a trial run before we convert these into ceramics, right? So I'm doing the trial run. I'm building up, and then I do freehand. And this is how I finish on the day. I said, Mona, go ahead, use them, come back, let me know how you feel. Something chips, something breaks. This girl disappeared, came back to me almost after a year and a half. Okay, a year and a half. Sometimes, it doesn't pay to do good provisional work, right? But it's okay. She's a friend. So, I knew she's saying, I'm traveling, I'm doing this. They have excuses, right? She had a good set. Now, when that composite started staining, as you can see, in this area here, the stains that she's developing, she now started getting, conscious about it. Because I hadn't spent time polishing it, nothing, just done a quick job and sent it away. Then we played around a little bit with the gingival zeniths, and I was wanting to give her veneers. Like I was trying to prep these for veneers. But as you can see, the decay was, pretty evident. I'm very gently going through a phase of preparation. Then I realized that the contact needed to be broken. So these are veneers which are wraparounds. They are not a full crown, but I'll show you them later. So these two teeth here, the two centrals, are actually veneers, but they're wraparound veneers because I wanted to build up this contact in ceramic. This is a full crown. This is a full crown. All lithium disilicate. These are veneers. And veneers on canines. People tell me, "Oh, how can you give a veneer on a canine?" It really doesn't matter. You adjust occlusion, you will get it spot on. This is your Protemp template with which I trim, and I gave her a joint provisional on the day. This is when she came back for the impression. You can do it on the same day. You can do it on another day. Choice is completely yours. So this is cord retraction. Second cord has been removed, and you can see how beautifully the retraction has taken place. Impression was taken. The lab sends you back these. So you can see in this that right here you have these wraparound veneers. They're not full crowns. These are full crowns, and these are just your regular veneers. Yeah, that's how the preps all done. That's how we finish a case on the day of bonding. Here I say bonding and not cementation. Yeah, and that's how we finish. So she sends me all these pictures, wherever she travels, and I don't know now where we will travel with all these lockdowns, but yeah. This was a case referred to me by my periodontist. She actually came to see my periodontist, who's very aesthetically driven. And the moment she looked at this, she said she needs a little bit of crown lengthening, but Akhil, I cannot do much with the restorative work. So I'm referring her to you. But first I'll do my crown lengthening. And this patient used to come to us from the US. So she would fly in. So she said, "See, I cannot keep coming back and forth. I'm only going to, I'm here this time, and the next time I want it all finished." So we said, all right, let's plan her case. And, this is my periodontist, starting with us. As you can see, this patient's already been through ortho. You can see those retainers that she has on the lower as well as the upper arch. She has a missing tooth here, and she's a very badly decayed premolar here. Sorry, this one here. Yeah. So we do the assessment for the crown lengthening. The crown lengthening procedure is over. As you can see how beautifully the suturing has been done, really beautifully done. And then we extracted these tooths. Then the periodontist extracted the tooth. She placed 2 implants. There was a sinus lift procedure done here, and the patient was sent back, asked to come back a year later. That's when she said she will come back, because we needed healing on the implants. We couldn't have loaded the implants immediately. So the patient comes back to me a year later, and this is how she does. She's got these little black triangles. Can you see this little black triangle here? It's a dentist nightmare. Now and also I want you all to notice here, this is also full-on composite work from right to left. You can see these huge composites everywhere. So scrape, scrape, scrape. We realize we can't, I'm trying to save veneers. No, not veneers. We end up with crown preps. Now this is just ready for impressioning. As you can see, I have placed my 2 implant posts here, my retraction done, impression taken, but see the tissue. I want you all to observe the tissue. Beautiful. The time you spend on your provisional, you get tissue like this, right? This is the BISC trial. Now here, I want to share with you all that these are Emax because they are on natural teeth. This is zirconia because they are on implants. So the choice of material is, I could have also done all of them as zirconia, but the fact that I like Emax on natural teeth is because you can bond it. Whereas zirconia, you can't bond, you cement, you lute, right? So the difference here. And I like bonding because it becomes a one monoblock. So these are my crowns. Bridge for the implant side, where we put in your abutments, screw them in, and we pick it up like this. So we match the shade of the upper and lower. And then I said, okay, Danny, I need some pictures, and then she starts posing for me, and I am trying to click some, and she was loving her smile. And she's actually a model, so it helped. She was modeling real. So that was before. This is after. These are some pictures, candid shots that I took just on the day of bonding her crowns. So coming to an end for today's presentation, I want to give you all some take home, and it's like a flow chart that I have created for impressioning. So you ensure that you have healthy tissue. Adequate retraction and hemostatic procedure has to be done. Appropriate trays, light body material according to the technique. Proper fitting, rigidity, and sturdy impression tray. Flimsy plastic impression trays don't work. Yeah? Tray adhesive, apply, dry, don't do it last minute. No, assure uniform and homogeneous mix of material. Fill tray with sufficient impression material. Don't be stingy. Use gloves that do not inhibit the setting of the material. Avoid air entrapment during the syringing. Apply controlled pressure on seating of the tray. Avoid any movements during the seating. So when you're setting, right, you keep it in place. Don't keep shaking it to check whether it's set or no. Stay within the working time of the material. Follow the setting time. When removing the tray, do it with the way I showed you all, the techniques that I showed you on how to remove a tray. Check if preparation margins are captured entirely. If not, you may have to go back and redo the entire thing. Disinfect impression. Why don't we disinfect an impression before sending it to your lab technician? Aren't they humans too? They could also contract the same diseases that you can when you are, when you are using your gloves in your patient's mouth and your masks and everything else. So please disinfect your impression. Rinse impressions after disinfection and then send it to the lab. A short video that I like to share at the end of my presentation. I can see Sagar already jumping up because that's something that he drives. If you have a good impression, that is how your crown will fit onto the patient's mouth. And no lateral interferences. You'll never be able to remove these crowns out. So I can't tell you that I can drive like this. I wish I could drive like this. But yes, I can take good impressions so that my crowns fit precisely on my tooth preparations. With that, I would like to say a very big thank you to everybody. Sorry about the glitches that came through. We had a few issues here and there, and typically network issues. These are all my contact details. You can contact me on Instagram, on Facebook. My email ID, my personal WhatsApp number is also here. If you want to share things, you want to say something about my presentation today, you're free to do that on all these social media platforms. I'm always available. I'm sure Sagar will be able to vouch for the fact that at any time he needs anything on a case, he picks up the phone, he calls me, I'm always there. If I'm working on a case, I don't normally pick up the call, but other than that, I will return your calls. I also do a lot of these courses, which are 1 day, 2 days. Now I don't know with the current scenario how things will, come into play. But we do a lot of individual training at my practice. So if 1 or 2 people, 3 people can come in and I can teach on a certain particular topic. These are a few things that I do. I love to share. I don't like to teach because I believe sharing is caring. Teaching, when you say teaching, it becomes like you have to give respect. Please, I'm just a humble Akil Reshamwala, nothing else. So with that, sir, Dr. Nayak, thank you very much for giving me this opportunity. Humble, thank you. Sagar, thank you once again. And thank you everybody who's been watching this either on Zoom or YouTube. Thank you very much for being a part of this. My pleasure.
Thank you, Dr. Akil. It was a wonderful lecture from your side, and we are looking forward to host you back again. We have got some questions and answers. Probably Dr. Sagar will take it up from here.
Yes, I'm happy to answer, sir.
Yeah. Akil sir, as always, fantastic, and you were at your charismatic best in your presentation, even though you were on Zoom and when you don't see the audience, but you are always like ever your charismatic best even in this. So there are a lot of questions that have come in. I would just like to take some, ones which are probably relevant and good. A commonly asked question, Akil sir, has been the choice of the retraction cord, the numbers vis-a-vis your gingival prototype. So can you just highlight that aspect for us?
See, first thing you need to address is which biotype your tissue is, whether it's thin biotype or thick biotype. See, thick biotype is the more forgiving type. So whichever, the fatter retraction cords that you will use there, it will still forgive you. So if you have a thin biotype, I like to start with a 00 or a 0 in the anterior zone. For the posterior, normally you end up with a little thicker type. So I start with a 0 and a 1. Very rarely I would use a 2. Very rarely, especially, where the distal border of your molars, you might need a number 2 sometimes. But other than that, these are my ones that I play with. And if I am doing a scan or I want to do a digital impression, then I might sometimes just place the first cord. That is, if you've seen in my videos, I place a 00 or a 0, and then I use that retraction paste, because there it causes expansion of that tissue with drying of that area. I mean, with the astringent effect on that area, and then I can pick up my impression. So I hope this helps people to understand the choice of cord. And the cord that I like to use, if you've noticed, I don't like to use a lot of names towards company products, but unfortunately, this is a cord which I cannot live without, is Ultradent Ultra Pack cord. because it's a woven cord. It's not a cord that frays. When you press on a cord, it should not open up and start, fraying. So always use a woven cord, and the Ultradent cord for me is my gold standard.
Thank you, sir. There's one more question that's coming from one of the participants. She's, of course, like a lot of them, appreciated your lecture and said, the question that's asked is there any particular type of crown that you choose for a case? I know you highlighted a natural tooth for an Emax and you were speaking about zirconia for the implant. But is there any kind of standardized rule that you follow when you decide which type of a metal-free or a PFM for a particular kind of tooth that you decide?
Okay. Now, unfortunately, in our country, it's all economy driven, right? So if the patient can't afford, you start with a PFM. But if I were to look at all ceramic, and that is what I would like to discuss, because people normally, they take an impression, send it to the lab and say, metal-free crown bana ke bhejo. It's that you have to tell the lab, because the lab cannot see what the tooth is, what you've done on that tooth. So now let's break it down into simple things. Natural tooth, vital tooth, no problem. You've done a crown. I would like to do an Emax or a lithium disilicate crown. Why? I could bond it. Endodontically treated tooth, no discoloration, perfectly good in the shade. I would again choose a Emax crown over there. If it's discolored, then I would look at zirconia. Now, if you have a missing anterior tooth somewhere, say a lateral, and you have to do a 3-unit bridge one side, but the other side you have all your intacts, like all your other teeth intact, then in that case, for the bridge, I cannot use lithium disilicate. I have to choose zirconia. So then I would choose zirconia here. And now the crown choice on the other side would also be zirconia, because they will match. Two different materials, two different consistency, two different translucencies don't tend to match. Also, my choice here will be the zirconia, which is translucent and not the totally opaque one, because I want it to look more natural. So I want that translucency. At the same time, I want the strength of zirconia. So then my choice would be zirconia, but the premium quality type zirconia, which is the translucent type. I hope, Sagar, I have tried to cover up the... And of course, with implant dentistry, you definitely can't use Emax unless you're making a zirconia abutment and then putting an Emax crown. I don't want to confuse people by going to the implant side on this webinar, because I've not touched anything there. So I'm going to keep it simple by just saying, I'm going to stay away from there.
Okay. Thank you very much. Yes.
Akil, Dr. Rakshina has a question for you.
Yes.
You can ask the question.
Hello. Hello, sir.
Yes.
Hello. Good evening, sir. Yes, sir. Good evening, sir. Sir, can you please tell me how we can temporize the veneers?
Veneers, simple. I use Protem again for doing my veneer provisionization, and I keep them all joined together. So before my preparation, the template that I've taken, now here the template, avoid taking alginate, do it in putty, putty material, because
Yes.
it's more rigid and it will hold the veneer more, delicately, because alginate is a little flimsy, right? So you put your Protem into that same putty, put it back into the patient's mouth, and when you pull it out, you'll find that they're all joined. But you need that Soflex to open up the embrasures where the interdental area is. If you don't open them up, or if you make them too open, it'll crack and it'll break. If you don't open them up, the soft tissue will recede. The interdental papilla will recede. So if I had done, I have a lot of images that I can show you of the veneer temps that I make. Sorry.
No, I think that answers the question. Yeah.
Yeah.
Dr. Akil, Dr. Abhiraj has a question for you. Abhiraj,
yes,
you have a question?
Hello.
Dr. Abhiraj, yes.
Hello. Yeah, good evening, sir.
Good evening.
Sir, how to play with the golden ratios and the Janeth line if patient is having some trouble with the smile lines?
My God, that is the whole lecture in itself, Abhiraj. But I'll try and do my best.
Sir,
Because,
some tricks that you can tell.
wow, there are too many, and I wish I had more time. Probably Dr. Nayak will kick me out now from there, saying that shut up. But I'll try as much as I can. See, I don't know whether you realize, but the golden proportion is no more a proportion that we follow in day-to-day practice. Because why is golden proportion is about actually measuring the tooth by itself. But do you see I show you my teeth like this? Do you see all my teeth? They're buckled? No, you see shadows, right? So
Yes.
parts of the teeth which are hidden behind that shadow, the contouring of the tooth. So all that, if you look into it, if you can get your hands on that article written by Christian Coachman on tooth shapes and it along with smile designing, which he's done for his DSD, you will get most of your answers, Abhiraj, over there. I wish I had more time to explain. I would love to, because if you can see, I get very excited with these kind of topics, because this is my I would say, I love doing work like this. So I would love to, but then to make it simple, these are the things that I would like to address.
Yes. Sir, another question.
Yes. Tell me.
Sir, you had told we can use a putty impression as a custom tray.
Yes.
Sir, in that you had placed a spacer over the previously taken impression die.
Perfect.
For the cast.
Perfect.
Can we use a spacer directly into the mouth and take a putty impression followed by removing the spacer and taking a light body?
No, Abhiraj, you can't do that, and I'll tell you why. Now it's a fantastic question, and I'm glad you asked me, because I wanted to talk about this topic, but I was looking at the watch and thinking I'm running out of time. I didn't want to. See, when you do it in the patient's mouth, first, any material, forget a spacer wax. A spacer wax to mold into the patient's mouth is a very difficult thing, because you first need to heat it. If you heat it and put it into the patient's mouth, what's going to happen? Patient's going to be really uncomfortable to start with. So what you do is you take that alginate, right? You pour that model up, and on that you do it. And because you need this spacer wax very aptly adapted to the model and not something which is loose, the reason being, every time there is a thickness increase of light body, there is a distortion of the impression poured. Now let me put this very practically to you. Okay, I have taken an impression, right? But my light body thickness, I'm going to exaggerate this so you understand it. This is my base. The lower part is my base, is my putty, but my light body is this thick. All right. Now what happens when I pull it out? I'm going to put it on my table, and then I'm going to get that dye stone, and I'm going to mix it, and I'm going to pour it into my tray. Right, Abhiraj? So once I'm doing that, the sheer weight of my dye stone in my tray causes the light body to compress because it is so thick. Are you understanding what?
Yes, sir.
Which causes your dyes to become larger than they actually are. Are you understanding what I'm saying?
Yes, sir. Yes, sir.
And that makes your crowns very loose on your tooth preparation, because they have been made on a larger dye.
Yes.
And then they have put a spacer, right? So
yes,
then
sir.
suddenly there's no retention. I had done a fantastic preparation, but the problem is the thickness of your light body. So now you know why you can't do it in the patient's mouth.
Yes,
that
sir.
Is why
yes, sir.
I like to see that technique which I showed you, right? Which I took a quick impression, direct, no spacer, nothing. This is in my mouth. I put it in my mouth. Yeah, I took it, and then I remove all the undercut. Now, how do I know for sure that my light body is going to be even thickness everywhere? Remember that slide, that ADS specification slide that I showed you, that putty can only record up to 75 micron and light
Yes,
body
sir.
goes to 25 micron. That means you have 50 micron. Now that is a good enough space for light body to flow through and give you a brilliant, perfect impression.
Yes, sir. Thank you, sir.
Because
Thank you, sir.
I hope the question is answered.
Yes, sir. Yes, sir. Yes, sir. Thank you, sir.
If
You're
you have
most
time,
welcome.
one more question, like Dr. Shubhra Pandey would like to ask.
Yes, sir.
Dr.
Um,
Shubhra, I am waiting.
Good evening, sir. So my question is about what is the material of choice for patient who are having a bruxism problem?
Material of choice as in the restoration, the crown.
Yes, sir. Yes, sir. Crown.
If the patient has no issues, like I said, you have natural teeth which are worn down. Okay, as a
Yeah.
prosthodontist, I will always tell people one thing: what can I change? I can
Yes.
change my restoration. I cannot change the tooth or the implant that I have placed in these bruxers, right? So once
Yes,
you
sir.
place them, you can. But if I tell my patient that I'm going to give you something which is going to wear down, just like you wore down your natural teeth. See, if he could wear down a natural tooth, everything that I put will wear. Now, what do I want to wear? I want them to wear the restoration, which I can change, or damage the tooth underneath by making my restoration extremely strong. So what I'm trying to get at is, if I am using zirconia as my restoration on top of it, right? The entire load of that is going to transfer to what is below. So that could be on your crown, your implant, or it could be the pontic of your bridge. That means your abutments. I would rather have the patient grind through my Emax, which is my layered ceramic. So always, preferably, don't use monolithic crowns, use layered crowns. Then it will be your choice if you want to use a zirconia base, as in your zirconia coping, or an Emax coping. I prefer Emax copings because I can re-prep them and I can give them a new crown. That will happen after 10 years, 15 years. It's not going to happen so soon. Yeah. So the
Yes.
wear capacity of Emax is equivalent to natural teeth. The wear capacity of zirconia is not. So it's a fine line where you choose what to give.
Thank you, sir.
Is there from Anupam Kumari? Anupam Kumari, can you proceed? Anupam?
Dr. Anupam, you will have to unmute yourself.
Okay.
You know, कौन बनेगा करोड़पति में लाइन टूट गया सर.
कोई बात नहीं सर. डॉक्टर जीवन कृष्णा है सर, वो आपसे एक सवाल करना चाहते हैं.
जी.
जीवन,
Can I ask for a helpline? Call a friend.
Possibly you are the helpline for all, sir.
Hello, good evening,
No,
sir.
sir, no. My pleasure, my pleasure.
Good evening, sir. Good evening, sir.
Good evening. Is that Dr. Jeevan?
Yes, sir. Yes, sir. Yes, sir.
Yes, Jeevan, tell me.
Sir, how can we check clinically that biotype is thin or thick, sir?
No, I couldn't hear you. Can you repeat your question, please?
Sir, how can we check clinically that the
Yeah.
biotype is thick or thin? How clinically how to check?
Biotype is thick or thin. You take a probe. You take
Yes,
a probe, a perio probe. All right. When you put a perio probe, imagine now if this is my tooth, right?
Yes,
And
sir.
this is my soft tissue. If I take a perio probe and I enter into the soft tissue here, into the sulcus, if I can see my probe, it is thin.
Yes, sir.
If I can't see it, it's thick. If you understand what I'm saying, that shadow of the probe will be seen.
Yes,
Now,
sir.
this is a very basic way of doing a thick and a thin.
Yes.
Please, if you are at the university, contact a periodontist. They will tell you exactly how to do it. I can share you articles, but clinically, this is a very quick and immediate way to figure out whether your tissue is thick or thin.
Thank you, sir. Thank you so much.
You're most welcome, Jeevan.
Sham Sundar Reddy is there. He's has a question for you. Sham Sundar, can you hear me?
If Sham Sundar gets off the London Bridge, then he'll be able to ask me the question.
There are some questions we can.
You can, Dr. Akil, if you desire, you can pick up some questions from question and answer section. Dr. Sagar may coordinate here.
Yeah, just a minute, sir. So you've kind of answered most of the questions that were in the Q&A section, Akhil sir. But there's this one question which asks, what is the
Yes.
margin design for veneers that you prefer as a clinician and prosthodontist?
A thin chamfer.
Okay.
Thin
Okay.
chamfer is what I prefer. See, veneers, the more you are in enamel, the better the bonding of the veneer to your tooth. So stay away from anything which is thick. Stay away unless required. Like if you noticed in my one case, Mona's case, when I had to open up the embrasures, that time in that area, I went a little thick because there I wanted strength on my lithium disilicate to be bulked up perfectly into that diastema area. Otherwise, thin chamfers is all that I would ask for.
Okay. Thank you, Akhil sir.
You're welcome.
Dr. Gurudat, would we have any more questions coming in?
Some tips for posterior crown reduction.
Can I request that person to please search for me on YouTube? There is a whole video on how to do the posterior crown prep. It'll just, everything is there. So
yes.
Yeah.
Okay. Thank you, Dr. Akhil. Thank you.
Thank you very much, Dr. Gurudat.
So we would just like to conclude, Akhil sir. We appreciate the time you've removed from your, I know you're a very busy practitioner, and Saturday evening, I know you work. You have made sure that you remove time for our dental college, Mansarovar Dental College and Mansarovar Global University. Sacrifice that practice time of yours in sharing your knowledge in depth about impressions, about which kind of materials you should use for which kind of cases. It was a highly interactive session, as you would have yourself seen with the number of questions that came up post the presentation. So thank you once again on behalf of Mansarovar Global University, Mansarovar Dental College. I, Dr. Sagar Khanna, extend my genuine thank you to you, and we look forward to seeing you in future again with your interesting topics. Thank you very much, Akhil.
Thank you very much. It was my pleasure. But Sagar, right now, as you probably know, with government rules, I'm not really working that hard as you portray. Stay home, stay safe. But nah, yes, thank you. It's my pleasure. Totally my pleasure. I would actually like to extend my thanks to Dr. Nayak. Dr. Nayak, thank you very much for giving me this opportunity. Yeah. And see, Sagar and me go a very long way. And, you know, I think you should put him on this position because his kind of work, I ask him doubts. So, you know, it goes both ways. Today he's hosting me and give me the opportunity to host him.
He's just being very kind, Dr. Nayak. That's very typical of him. Yes.
Yeah. That's very nice.
Thank you very much.
Okay. Thank you.
Thank you very much.